Imagine you survive a highly aggressive cervical cancer. You go through like the grueling diagnosis, the intense surgery, and you finally come out the other side.
Right. It is a massive medical triumph.
Exactly. The doctor tells you the cancer is completely gone. But then you slowly realize the surgery that saved your life has permanently taken away your ability to control your own bladder.
Which is just a devastating realization for any patient to wake up to.
It really is. So today we are looking at the unintended collateral damage of what is otherwise a totally life-saving procedure. Welcome to another personalized deep dive.
Glad to be here for this one.
We've got a stack of clinical studies, urodynamic research, and international assessment standards that you sent over. And our mission today is highly specific.
It's a tough but fascinating question.
Right. Can a previous radical hysterectomy disrupt the autonomic innervation of the bladder neck and cause severe stress urinary incontinence?
It's a question that really forces us to look past the primary goal of oncological surgery, which is obviously eradication of the disease, right?
Right.
And it makes us examine the massive, sometimes invisible toll it takes on a patient's day-to-day existence.
Yeah. Let's ground this in the clinical reality before we get into the anatomy. We are talking specifically about patients with early-stage cervical cancer.
Yes.
In the medical literature you provided, this is classified as FIGO stage IA to IIA.
That's right.
And for those wondering what that means, it basically indicates the cancer is strictly confined to the cervix and maybe like the upper part of the vagina.
But it hasn't spread widely through the pelvis or to distant organs.
Exactly. And because it's caught early, the survival rates after surgery are incredible. I mean, we are talking over 80 to 95% at 5 years.
Which is absolutely phenomenal.
Yeah.
But because these patients are surviving and living long, full lives post-surgery, the long-term functional outcomes become incredibly important.
Yeah, it's not just a quick recovery phase.
Exactly. A drop in quality of life isn't just some brief post-operative hurdle. It's something they might have to manage for decades.
So, to understand how a surgery aimed at the cervix causes permanent bladder issues, we really need to map out the territory.
Anatomy is everything here.
Right. There is a huge difference between a standard hysterectomy and a radical one, and it all comes down to the collateral tissues.
Right, the surrounding structures.
If someone has a benign condition, say painful uterine fibroids or myomas, a surgeon might perform a simple hysterectomy. They just remove the uterus and the cervix, and they stay very close to those organs.
But cancer doesn't respect anatomical borders.
Right.
So for cervical cancer, surgeons perform a radical hysterectomy. They can't just take the uterus and cervix. They have to take the surrounding scaffolding to ensure they get clear margins.
And that scaffolding includes the perimetrium, right?
Yes. That's the connective tissue and fat separating the cervix from the bladder at the front and the rectum at the back. And also the pericolpium, which basically suspends the vagina.
The sources give us a really vivid anatomical breakdown of this area. And the problem is that scaffolding is absolutely packed with invisible wires.
Beautifully put, yes, the autonomic nervous system.
We're talking about 3 main structures at risk, according to the studies. First, you have the hypergastric nerves.
Which carry the sympathetic signals.
Right. Then the pelvic splanchnic nerves, which are parasympathetic and branch out from the lower spinal cord, specifically the S2 to S4 sacral nerve roots.
Correct.
And finally, there's the inferior hypogastric plexus, where all these nerve fibers kind of merge and weave together.
Yeah, that plexus is the critical junction box for the entire pelvis.
Wow.
And you have to realize, these nerves don't look like thick, obvious cables that a surgeon can easily just push aside.
They're hard to see.
Very. They form a flat, delicate meshed band plastered right onto the lateral wall of the upper third of the vagina.
Just right there in the surgical zone.
Exactly. And from there, they send tiny postganglionic fibers straight into the bladder and the bladder neck.
Okay, let's unpack this. It sounds like performing a radical hysterectomy is essentially like trying to safely remove a massive diseased tree from your yard.
I love this analogy. Go on.
Well, you have to get all the roots to make sure the rot doesn't spread, right?
Right.
But those roots are completely tangled in this complex, invisible network of underground sprinkler pipes and electrical wires.
That is a perfect way to visualize it.
So you just can't avoid hitting the wire.
Right. During a classical radical hysterectomy, the surgeon is hyper-focused on the disease tree. The most damaging steps are the resection of the vaginal, anterior, and posterior perimetrium.
Because they have to get a wide enough margin of tissue around the cervix to guarantee the cancer is gone.
Exactly. They have to cut deeply into that connective tissue. And because that delicate mesh of nerve fibers is completely embedded in those surrounding ligaments,
They just get taken out with it.
yeah, taking the tissue intrinsically means removing or severely traumatizing those nerves.
So we know the wires are getting cut. Let's connect that directly to the core mission of this deep dive. How does severing those specific wires translate into severe bladder dysfunction?
And specifically stress urinary incontinence.
Right, how does that happen?
Well, we have to look at the bladder's dual control system. It's a beautifully balanced mechanism that operates entirely without our conscious input.
It's all automatic.
Exactly. The parasympathetic nerves, those splanchnic nerves from the sacral roots you mentioned, they are the emptying signals.
So they tell the bladder to contract.
Right, they trigger the bladder muscle to squeeze when it's time to go. The sympathetic nerves, on the other hand, are the storage signals.
And just to clarify, the sympathetic signals are coming from the hypogastric nerves, right?
Correct. And they do two things simultaneously. They tell the main body of the bladder to stay relaxed so it can fill up, and crucially, they constrict the internal urethral sphincter.
Ah, okay.
They send a constant stream of what we call alpha adrenergic stimulation directly to the bladder neck.
Alpha adrenergic stimulation. I want to make sure we don't gloss over that for you listening.
It's a key concept.
Because if we think about adrenaline, the adrenergic system is about tightening up,
Right?
getting ready for action.
Yes, exactly.
So this alpha adrenergic signal is essentially like a chemical bouncer standing at the door of the bladder neck, just keeping it tightly closed while the bladder fills.
That's a great way to put it. And that bouncer is working 24/7. Now imagine what happens when the surgeon cuts the hypogastric nerves in the perimetrium.
You instantly lose that sympathetic alpha adrenergic stimulation.
Right, and if we connect this to the bigger picture, the loss of that signal has a paradoxical excitatory effect on the sphincter mechanics.
Meaning, without the constant command to hold tight, the bladder neck undergoes permanent relaxation.
The door just swings open.
So the bladder neck basically becomes a leaky faucet.
Yeah, if you sever the sympathetic nerves, the sphincter completely loses its resting tone.
Wow.
The clinical term for that loss of periurethral tone is a decreased maximal urethral closure pressure, or MUCP.
MUCP, got it.
That drop in closure pressure is the primary mechanical driver of postoperative severe stress urinary incontinence.
Because when you cough or sneeze or laugh, the physical pressure inside your abdomen spikes.
Exactly. And without that chemical bouncer keeping the sphincter clenched, the physical pressure easily overwhelms the relaxed bladder neck, and the patient leaks urine.
But the clinical studies in our stack reveal that this dysfunction doesn't just, happen overnight and stay static.
No, it evolves over time.
The sources map out a difference between early and late postoperative dysfunction.
Yeah, so in the early phase, usually the first 3 to 6 months after the surgery, the bladder is in a state of acute neurogenic shock.
What does that look like for the patient?
Well, patients often experience decreased bladder capacity. The bladder just won't hold much urine, and they have a deeply reduced sensation of needing to go.
And then the late dysfunction sets in, which introduces this concept of reduced bladder compliance.
Right.
What does compliance actually mean physically in this context?
Think of a healthy bladder like a highly elastic, high-quality balloon. As you fill it with water, it stretches easily, right? It accommodates more volume without the internal pressure rising significantly.
Okay, so high stretchiness equals high compliance.
Exactly. But late-stage nerve damage turns that balloon into a thick, stiff leather pouch.
Oh, that sounds awful.
It loses its elasticity. So as urine fills the bladder, it just can't stretch. The pressure inside spikes dramatically, even at really low volumes.
And you combine that stiff, high-pressure bladder with the permanently relaxed bladder neck we just talked about.
And you have a perfect recipe for severe stress incontinence.
This mechanical explanation makes total sense. Cut the sympathetic wire, the valve stays open, the bladder gets stiff, you leak.
It's straightforward mechanics.
Right, but this is where the deep dive gets really fascinating, because when we look at the actual clinical data you provided, we run into a major contradiction.
We really do.
The sources give us a classic data duel about what type of incontinence these patients actually experience in the real world.
The historical context is important here before we get to that duel.
Okay, set the stage.
Before modern techniques, the rates of urinary dysfunction after a traditional radical hysterectomy were just staggering. They were reported to be as high as 70%.
70%. That's a massive population of women dealing with profound quality of life drops.
It was a widely accepted, albeit terrible, cost of the cure.
So, getting to the contradiction, one of the studies in our stack notes that stress urinary incontinence is significantly higher in classical radical hysterectomy.
Right.
Somewhere between 13% and 41% of patients experience it, which lines up perfectly with everything we just discussed.
It fits the mechanical model perfectly.
But then we have this major study by Shin et al. They looked at 289 patients,
Those are a very solid sample size.
and their data totally flipped the script. They found that stress urinary incontinence was actually more likely to occur in the simple hysterectomy group.
Which seems completely counterintuitive based on the anatomy.
Right. I mean, here's where it gets really interesting. How do we make sense of that for the listener? We have one study saying classical RH causes up to 41% stress incontinence, but another study saying simple hysterectomy actually causes more stress incontinence.
And it gets more complicated when you look at what the radical group did experience in that study.
Yeah. The Shin study found that urgency urinary incontinence, or UUI, was highly prevalent in the radical hysterectomy group.
The odds ratio was 6.4.
Meaning, if you had a radical hysterectomy, you were over 6 times more likely to get urge incontinence.
Right, the sudden, uncontrollable need to go.
Rather than the stress leaks from coughing or sneezing. I have to admit, this totally threw me.
It's confusing at first glance.
If the sympathetic nerve is cut and the door is left open, shouldn't they just be leaking all the time? Why are they experiencing massive urges?
It's a brilliant paradox and requires us to look at how symptoms mask each other clinically.
Okay, break it down.
The urge incontinence we see in these radical hysterectomy patients is often a misnomer on the questionnaires. It might actually be a severe form of overflow incontinence driven by sensory loss.
Wait, overflow? I thought incontinence meant the bladder couldn't hold anything. Are you saying it holds too much?
Exactly. Think back to the parasympathetic nerves.
The splanchnic nerves from the sacral roots?
Yes. We talked about how the sympathetic nerves get damaged, but in a radical surgery, the parasympathetic nerves get caught in the crossfire too.
Okay.
And those parasympathetic nerves are responsible for two things: squeezing the bladder to empty it and sending the sensory signal to the brain that says, hey, we're getting full.
Ah, so the brain never gets the text message.
Exactly. The sensory wires are cut, the patient goes about their day drinking water, and they literally do not feel the normal, gradual urge to urinate.
Because the sensor is broken.
Right. So the bladder fills.
Yeah.
And fills and fills. And because of that, reduced compliance.
The stiff leather pouch effect we talked about?
Yes. The pressure inside is building to extreme levels.
So they don't feel a thing until the bladder is at absolute maximum bursting capacity.
Yes. By the time the mechanical pressure is so high that it finally triggers whatever faint sensory pathways are left, it's an absolute emergency.
Oh, wow.
The pressure completely overwhelms the weakened sphincter tone at the bladder neck. The patient experiences a sudden, catastrophic loss of urine before they can even make it to a restroom.
And on a clinical questionnaire, that gets recorded as urgency urinary incontinence.
Right, because the patient says, I felt a huge urge and then I leaked. But the root cause isn't a hyperactive bladder. The root cause is sensory loss leading to massive overflow.
That is a brutal mechanism. The bladder is overflowing like a sink left running with a blocked drain, but the brain has no idea because the alarm system was snipped.
It's devastating for the patient.
And the sources mention that this whole situation gets exponentially worse if the patient needs adjuvant radiation therapy.
Right, radiation adds another layer of complexity. Radiation is incredibly effective at killing microscopic cancer cells, but it doesn't distinguish between cancer and healthy tissue.
So it damages the bladder too?
Yeah, radiation induces fibrotic changes in the bladder wall. Fibrosis is essentially widespread internal scar tissue, and scar tissue is rigid. It doesn't stretch.
So it takes that stiff leather pouch and practically turns it to concrete.
Precisely. The compliance drops even further, meaning the pressure spikes even faster, which just compounds the overflow and urgency issues.
So if a surgeon is looking at this, faced with this kind of devastating collateral damage, the surgical field clearly had to evolve.
They had to. Urologists and gynecologists realized they couldn't keep sacrificing bladder function for the cure. They had to figure out how to see the invisible wires.
And that necessity birthed a true paradigm shift in gynecologic oncology, right?
Yes. The nerve-sparing radical hysterectomy, or NSRH.
The entire philosophy of this procedure is to permit the complete removal of the oncologically relevant tissues.
Getting every last bit of the cancer.
Right, while actively, visually preserving those pelvic autonomic nerves.
And the technical specifics detailed in the sources are just mind-blowing.
Yeah, the surgeons aren't just being like generally more careful. They are actively hunting for these microscopic
It's
structures.
highly targeted dissection.
The studies mention they identify the hypogastric nerve in the mesurator, which is the tissue surrounding the ureter, usually finding it about 2 to 3 centimeters beneath the ureter itself.
Right.
And then they meticulously dissect the inferior hypogastric plexus to peel it away from the lateral parametrium before they remove the tissue.
It is painstaking, highly specialized work. And the clinical outcomes of taking this extra care are undeniable.
What kind of outcomes are we looking at?
Well, we can look at a very practical metric. How long a patient needs a urinary catheter after surgery.
Okay.
In classical radical hysterectomies, patients often go home with catheters for extended periods. But with nerve-sparing surgery, the postoperative catheterization duration is drastically shorter.
How short?
It averages about 6.9 to 13.4 days.
The sources mention that duration is actually comparable to a simple hysterectomy, which is a huge win.
It is a massive improvement.
They also track a metric called post-void residual volume, or PVR. Right.
Yeah, PVR is exactly what it sounds like. It measures how much urine is left sitting in the bladder after the patient actively tries to empty it.
A healthy bladder should empty almost completely, I assume.
Clinicians look for a target of less than 50 milliliters, which is roughly a standard shot glass worth of fluid, to consider the bladder functioning normally again.
And the timeline difference here in the studies is really striking. For nerve-sparing surgery, it took a median of 11 days for patients to reach that healthy target.
Right.
But for classical radical hysterectomy, it took 18 days.
Almost twice as long.
But, if you're listening to this, you're probably asking the exact same fundamental question any patient would ask.
About the cancer.
Right. If the surgeon is purposely leaving tissue behind to spare these nerves, aren't they risking leaving the cancer behind?
It is the ultimate fear, and it's a completely valid one. But the data over the last decade provides profound reassurance.
What does the data say?
Extensive studies show that nerve-sparing radical hysterectomy has become standard practice for early-stage cervical cancer precisely because it offers comparable oncological outcomes.
Comparable.
The survival rates and the recurrence rates are effectively identical to classical surgery.
So you literally don't have to trade your autonomic nervous system for your life.
You don't. But the transition to these nerve-sparing techniques also forced the medical community to figure out how to objectively measure success.
Because you can't just ask a patient, hey, how does your bladder feel?
Exactly. You need hard data to know if the nerves are actually preserved or damaged.
Which brings us into the world of urodynamic studies.
This is where they actually hook up sensors to measure the flow, pressure, and capacity of the bladder in real time.
And when they test patients who had classical radical hysterectomies, the objective parameters are pretty stark.
Very stark. They show lower maximal flow rates, that large post-void residual volume we just talked about, and impaired detrusor contractility.
The detrusor is the main muscle of the bladder wall, right?
Right. Impaired contractility means the muscle just cannot mount a strong enough squeeze to push the urine out, usually because those parasympathetic nerves are damaged.
And the visual imaging that accompanies these urodynamic studies paints a pretty grim picture. The sources highlighted a specific radiographic finding called a hairy bladder wall,
Yes.
which honestly sounds totally bizarre.
It's a very descriptive term for a complex physiological reaction.
Okay, explain the hairy bladder.
When they fill the bladder with a contrast dye and take x-rays, a healthy bladder wall looks perfectly smooth, like a normal water balloon.
Sure.
But a neurogenic bladder one that is damaged by nerve loss looks entirely different. Because the bladder is constantly trying to push against a dysfunctional system, the detrusor muscle starts to hypertrophy.
It gets bigger.
It thickens, kind of like a bicep after lifting weights. It forms thick, irregular bands of muscle called trabeculations.
So when the contrast dye seeps into all the deep crevices between those thickened muscle bands, the edges of the bladder on the X-ray look fuzzy or hairy.
Exactly. The imaging also notes massive increased bladder volume.
The overflow effect.
Right, and crucially, an insignificant bladder neck opening during the voiding phases. So the bladder is massive, the walls are thick and exhausted from struggling, and the exit door barely opens when it's supposed to.
Man. And the tricky part is figuring out a universal language to measure all this damage. Gynecologists actually had to look outside their own field to find a standardized grading system, didn't they?
They did. The sources reference something called ISAF-SECI.
Right, the international standards to document remaining autonomic function after spinal cord injury.
It's a brilliant pivot by the medical community.
Because that was designed for trauma patients, right?
Right. While ISAF-SECI was designed for patients who suffered traumatic spinal cord injuries, like from a severe car accident, it highlights a universal truth.
Which is?
The nervous system is a continuum. Whether the nerve damage happens in the spinal cord trauma unit or deep in the pelvis during an oncology surgery, clinicians need a systemic, objective tool to map what autonomic function remains.
And we really have to ground all these objective measurements in the human experience. When these urodynamic tests are bad, the management strategies are just intense.
Very intense. We're talking about clean intermittent catheterization, or CIC.
One of the studies noted that up to 30% of classical radical hysterectomy patients had to continue using CIC long-term.
Let's talk about what that actually means for a patient.
Yeah.
It means the patient's parasympathetic nerves cannot empty the bladder. So several times a day, every single day, the patient has to manually insert a sterile catheter up their urethra into their bladder to drain the urine.
It's completely life-altering. I mean, you have to plan your entire day around hygiene, finding clean public restrooms, managing all the supplies.
Not to mention, constantly introducing a foreign object into the urinary tract inevitably leads to recurrent urinary tract infections.
Which require antibiotics, which cause their own cascading health issues.
And here is a critical nuance hidden in the data about quality of life. What's fascinating here is that despite the physical drop in that maximum urethral closure pressure after a classical surgery, some patients don't immediately report worse incontinence scores on their post-op questionnaires.
Wait, really?
No.
If the chemical bouncer is gone and the pressure drops, why wouldn't they notice they are leaking?
It likely comes down to demographics and muscular compensation.
Okay, what does that mean?
Cervical cancer patients are generally younger. A younger patient typically has strong, healthy pelvic floor muscles, the muscles you use when you do Kegel exercises.
Right.
These voluntary muscles can act as a backup bouncer. They physically clamp down to compensate for the loss of sympathetic nerve tone at the bladder neck.
So they are actively masking the symptom.
Yes, exactly.
But nobody's muscles stay perfectly toned forever.
Precisely. As these women age, natural tissue laxity sets in. Menopause changes the tissue integrity. Eventually, those pelvic floor muscles just can't maintain the heroic effort of compensating for the dead nerves.
The structural integrity has been compromised for years.
Right.
It just takes time for the final collapse.
So a patient might think they entirely escaped the bladder issues, only to be hit with severe stress incontinence a decade later.
Wow, that really drives home why nerve-sparing techniques are so critical from day one. To recap the journey we've taken through your sources today, yes, the data is totally clear. A radical hysterectomy can definitively disrupt the sympathetic hypergastric nerves innervating the bladder neck.
Completely severing the connection.
Right. This severs the alpha-adrenergic signal, leading to a permanent loss of tone. That causes severe stress urinary incontinence, or, if the sensory nerves are also cut, a complex and devastating overflow incontinence.
A terrible outcome.
However, surgical innovations like the nerve-sparing radical hysterectomy are actively rewriting this story, proving that curing cancer doesn't have to mean sacrificing the patient's future quality of life.
It's a profound testament to the evolution of surgical precision.
Yeah.
I mean, the field is moving from the blunt force eradication of a tumor to a nuanced, microscopic preservation of the patient's entire autonomic ecosystem.
For you listening, diving into the mechanics of this invisible autonomic network really highlights just how deeply interconnected our body systems are.
Oh, without a doubt.
The wires controlling a vital daily function are tangled right into the structural supports of our reproductive organs. It's just a stark reminder of the delicate, high-stakes balance surgeons must strike every single time they enter the operating room.
It truly is. And, as we synthesize this data and look toward the future, it raises an incredibly provocative question for you to think about.
Oh.
If surgery can unintentionally alter these autonomic pathways and permanently relax the bladder neck, could the future of urology lie in targeted neuromodulation?
Like implants.
Yeah. Imagine a tiny implant, essentially a pacemaker for the pelvic plexus, a device that artificially generates and sends those lost sympathetic alpha-adrenergic signals to keep the bladder neck closed.
Oh, wow.
It could potentially cure incontinence entirely. completely bypassing the need for intact nerves altogether.
A pacemaker for the pelvis. From the murky, invisible collateral damage of the past to the targeted electrical precision of the future, that is definitely a thought to chew on. Thank you for joining us on this deep dive.